Hi everyone, welcome back to Medreader. In today's lecture, I want to discuss about the most common medicine these days that we prescribe for mortality improvement and heart failure. It's everyone knows it's ARNI. It's picking up in a lot of medical conferences. You hear about this medicine and try to introduce in your heart failure patients as their blood pressure and renal function allows these days. So it's really important to discuss this, and it's also heavily tested on boards. So let's do some slides on that today. Okay, so why ARNI? Like, what's so different? It's just that ARNI has an neprilysin inhibitor attached to the usual ACE and ARB, which in this case is valsartan. So sacubitril, which is a neprilysin inhibitor that is added to valsartan, it actually stops the degradation of your physiologic BNP and ANP. So this gives you more vasodilation as well as improvement in your perfusion, and at the same time gives you more diuresis. So it's a natural diuretic that your heart releases a form of neurohormonal response, and that acts in your favor of heart failure patients. So we just amplify that and suppress the ROS system. Right, so a quick physiology slide behind this. As you may all know, in heart failure, you have elevated filling pressures of your ventricles. So the catalyst here is the stretch that is caused by these elevated filling pressures, and you have some endogenous response to it. The endogenous response is the release of these hormones, which are BNP and ANP, is going to cause more diuresis and vasodilate to improve perfusion pressure. So in a way, your heart's response and congestion to increase more diuresis and dilate the vessels. Okay, so this slide just explains what we discussed previously. You're going to, when you inhibit the neprilysin with sacubitril from the ARNI, you're going to get more ANP and BNP. You're going to get diuresis, vasodilation, and inhibition of aldosterone secretion. Now, this is only one part of what's true. Neprilysin is also, responsible for degrading angiotensin 2. And when you inhibit neprilysin, it's not going to do that. So you're going to have more of the angiotensin 2 mediated effects, which you will need to counter with valsartan. We're going to discuss in further slides. All right, so you inhibit the neprilysin and you have twofold effects. As we discussed, it increased ANP and BNP, more diuresis, more vasodilation, more perfusion, decreased aldosterone. But it's also going to increase your angiotensin too. So you will need valsartan to stop the RAS system. Valsartan acts as a pharmacologic shield. It neutralizes the detrimental RAS activation that's caused by the neprilysin inhibition. So they kind of like coexist together to mediate the physiologic effect and to stop the RAS system together, which is more added benefit. You're decreasing aldosterone, you're stopping the remodeling of the heart, just like you did with ACE and ARBs. But the decrease in the hospitalization rate, it comes with more diuresis that you generally get with ARNI. Because remember, ANP and BNP are preserved. You're gonna get more high levels as you test patients for BNP when they're in exacerbation, and that's why for patients who are on ARNI, you do not, measure the BNP or take it into account of how their heart failure is doing. So just a bonus point. And here's what's important to remember, even for the boards. HFpEF patients with preserved EF, they don't need ARNI. It's not indicated, and it's also not indicated just as in any other blood pressure medicine. It's only useful for HFrEF. Your EF is reduced, the remodeling physiology that is associated with HFrEF, ARNI, the things we discussed before, is going to stop only HFrEF physiology, not for any other heart failure type or blood pressure in that terms. So how are these two combination medicines eliminated from the system? So sacubitril, the neprilysin inhibitor part, it's actually cleared by the renal system. And valsartan is gonna undergo hepatic clearance with biliary excretion. So this is important to remember. If your patient had AKI or liver failure, the levels of these are going to increase. And it's important to remember, especially about the sacubitril, because that's the component which is going to lead to angioedema, which is also a pronounced effect for ACE inhibitors. And remember, just like ACE inhibitor, neprilysin inhibitor is going to increase your bradykinin levels. Bradykinin is a potent vasodilator, and it increases your vascular permeability. It's going to cause the classic symptom of dry cough in patients with heart failure who are taking this, and it can also cause angioedema in about 2 to 3% patients. It's a rare side effect, but it's also similar to taking an ACE inhibitor. ARNI comes with the side effect of angioedema. Important for boards. What not to do. Do not combine ARNI with an ACE inhibitor for the obvious things we discussed in the previous slide. You're going to have a storm of bradykinin, and that's not good for the heart failure patient. So they're going to present with elevated angioedema risk, because now you have the percentage from both the medicine that you combined, and you're going to have more cough presenting. So it's a big no-no if you see on the boards too. All right, so in terms of side effects, you have three major to remember. Hypotension, it's actually the most frequent side effect of an ARNI. Hyperkalemia, driven by the reduced aldosterone activity, which is going to cause your potassium to be retained in the body, very similar to ACE-ARBs. You're going to have AKI, and it's going to be driven by the angiotensin II mediated vasoconstriction of the renal efferent arterioles, similar to the ACE-ARB family. So these three symptoms actually are pretty similar to what you get from ACE and ARBs. Pretty much like ACE inhibitor and ARBs, ARNI therapy is also it also has fetal risk, so it's not indicated in someone who is trying to conceive, or it must be, immediately discontinued in someone who in whom pregnancy is detected, because it causes renal agenesis. It's not sustainable for fetus, and this should be on your board somewhere, so just keep in mind. And some of the factors that you need to consider when you are about to start ARNI is if they have hypotension, if the blood pressure is already soft at baseline, if they're on any other medicines that can increase your potassium, or if their potassium is already high and you haven't figured out why yet. So in those patients, you might have a low threshold to start on other forms of medicine, and would be something that a PCP needs to do at a follow-up. Again, you have active kidney injury. If you have patients presenting with true AKI, don't do that. And if they have history of angioedema, it's actually contraindicated in that case. And as we discussed in the previous slide, pregnancy. So to summarize, remember, sacubitril is a neprilysin inhibitor that is combined with valsartan to get the positive effects of ANP and BNP, more diuresis, and inhibition of the RAS system with the valsartan. Indications only indicated in heart failure with reduced ejection fraction, not for anything else. And the adverse effect profile might want you to limit the use in cases that have more cough, angioedema, absolute contraindication, hyperkalemia, AKI, hypotension, all these kind of similar to the ACE and ARBs. So um, yeah, this, topic is discussed on boards, and I hope you learned something from this video, and we'll see you in the next one.